weight, your prostate is on the average about 10 to 11 grams, and it will grow regardless of what one does. It will be the size of a ping pong ball. And by the time one gets to like 80, 85, it can get to the size of a tennis ball. Shape-wise and size-wise is the size of a walnut, and it seems to have like 2 lobes, and it is located just below the bladder and right above the rectum. And that location is important in terms of diagnosis. When the doctor has to do a DRE, which is the direct rectal examination of the prostate. Functionally, it has some arsenal parts of it, and it also has a glandular portion of it. Most of your prostate cancer develop from the glandular tissue, and that's why most of prostate cancers are adenocarcinomas. That is related to the glands. Okay. Now the prostate, of course, produces your PSA, prostate-specific antigen, and it also contributes to the semen. It provides an alkaline, milky substance to the ejaculate of the semen. Now the PSA, prostate-specific antigen, can be used in screening for, prostate cancer. It can be used to gauge the effectiveness of therapy. Okay. So it can be used for monitoring purposes. Okay. It can be used for diagnosis, but it is not very reliable in that sense. And the reason is because your PSA can also go up when you just have benign prostatic hyperplasia. Your PSA can also go up when you just have an infection of the prostate gland. So the normal should be 0, but they always say that 0.4 nanograms per mil of PSA is normal, and that by the time you get to 4 nanograms, you probably have BPH, and if you get to 10, then you're probably looking at some tumor development. But like I said, those are not very definitive, because we now know today that this 0.4 itself is age-related. So what's normal depends on what age group the person is. So those are just numbers that we throw out. Okay, so that's for your prostate in terms of its anatomy. It has a transitional area, and it has a peripheral portion of the gland, or the prostate, and you have another that is called the central. All these are zones of your prostate gland. And you have a lot of the cancers coming from the transitional and from the peripheral areas, not necessarily from central. Okay, the prostate gland, of course, can become tumorous under certain conditions, such that you can have your prostate cancer. And when we say prostate cancer, as we say, the most common one is the adenocarcinoma, but you have other forms of prostate cancer. For instance, you can have the squamous cell carcinoma. That is a type of prostate cancer. And you can have the transitional duct. Transitional duct carcinoma, another type. If you ever find prostate cancer in a child or a young man, that is usually a sarcoma, not an adenocarcinoma. So the only time you see a prostate cancer in someone who is below 30 years of age is usually this type of prostate cancer, the sarcoma, which means it affects the connecting tissues. So to deal with prostate cancer, prostate cancer tends to express a certain protein that is actually antigenic on its surface. And that prostate antigen that is expressed on the surface is peculiar, specific for prostate cancer. And so that understanding or that knowledge is used to make some drugs one particular drug that is used to treat prostate cancer. And so when we get to drugs, we will talk about Sipuleucet T, which utilizes the specific antigen that prostate cancer cells elaborate on their surfaces. Okay, so in terms of the origin, we don't know exactly how prostate cancer forms, just like every other cancer. But you know that there are certain things that would increase the risk of developing prostate cancer. And that the development, the pathogenesis, or the disease condition is usually genetic in nature. So there are genes that are involved. Okay. And for prostate cancer, you have a gene that is called HPC1. That is hereditary prostate cancer gene 1. Okay. And then you have BRCA, which is just prostate cancer gene 1. And as we've mentioned before in the past, your BRCA is also associated with prostate cancer. That's the breast cancer gene, both 1 and 2. So BRCA1, BRCA2 are also involved in prostate cancer. And your mutated P53 gene is also involved in prostate cancer development. And whenever you have a downregulation of the KI gene, KAI, a downregulation of KI gene will result in prostate cancer. This is one aspect of your platinum coordination complexes, like cisplatin, that is not talked about enough, because cisplatin can upregulate high, which means it would be helpful in prostate cancer management. Okay. Some other things that can increase one's risk of getting prostate cancer would be if you, like any other cancer, if you have or if you're ingesting a lot of fatty material or fatty food, you know, if you have a lot of insulin-like growth factor. Insulin-like growth factor promotes the growth of cancer cells in the prostate gland. And if you have had vasectomy also increases the risk along the ablation line. We can put in here orchiectomy as the removal of the testes. Orchiectomy will decrease the risk of prostate cancer, whereas vasectomy will increase the risk for your prostate cancer. Other things that can lower the risk would, of course, be increasing the ingestion of vegetables and fruits, as opposed to red meat and fat. Your zinc tends to reduce the risk. Selenium also tends to reduce the risk. Lycopene, which comes from tomato, that drastically reduces the risk of prostate cancer if you ingest a lot of tomatoes. So all of those can decrease the risk. If you ingest salt palmetto, you can also see a decrease in the risk for prostate cancer. And we'll mention salt palmetto again on the drug side. Okay. Now, the prostate cancer and the scored or measured based on how fast and how aggressive it is. There is a score that is called the Gleason score. What they do in Gleason score is to take each lobe of a prostate and assign a number 1 to 5 to each one. So the left lobe 1 to 5, the right lobe 1 to 5. Okay. And whatever number you get, you basically multiply by 2. In other words, if you look at the right lobe and you had a Gleason score of say 2, you multiply it by 2 because you expect the other lobe to be involved, and then you get your Gleason score. Gleason score of 2 will mean that you have a very slow growing, that is non-aggressive prostate cancer. If you're getting to Gleason score of 6, 8, not to mention 10, then you have a very aggressive prostate cancer that is deadly, kind of. So the Gleason score is used to determine how rapidly growing your prostate cancer is and how deadly it has become. And whenever you see undifferentiated, word attached to any cancer, that means that it is aggressive. Okay, so it does not care about function. It just cares about growth. And so a well-differentiated prostate cancer then will be one that is slow growing because it still cares about function and it is not aggressive. A diploid prostate cancer will be one that still contains the normal 46 chromosomes, if you will, of a normal cell, normal somatic cell. So that will be less aggressive, slow growing and less aggressive. But an aneuploid will be one that will be deadly, that will be very fast growing, and very aggressive because you don't have 46 chromosomes. You have varying numbers of the chromosomes in cells. So that's how we determine how aggressive that prostate cancer is, and that will shape what you do in terms of modality. What are some signs and symptoms that you can see? You divide those into 2. The ones that are due to blockage, if you will, and the ones that are due to metastasis. These are also sometimes called obstructive. The symptoms of prostate cancer. So the ones that are obstructive or the ones that are related to blockage, basically you're saying that the prostate gland has grown enough to choke the urethra, because it's located within the first inch of the urethra in the male, so it can choke it off, and that will mean then that patient will have difficulty in initiating urination. They will have to go to the restroom and press in for a long time before a tiny drop of urine will come out. So initiation of urine flow will be difficult. The total amount that they are even able to get out will be scanty. Will be very small. So scanty urine formation, scanty urine flow. And they will have this sense of incomplete evacuation of the bladder. So they can urinate now or get a few drops out. 3 minutes later, they feel like their bladder is full again. They have to go back to the restroom. Things like that. However, the frequency will be there. They will have frequency in terms of how often they go to urinate. The urgency will also be there. They will feel like they have to urinate. So frequency and urgency, and then there will be increased urination or tendency to go to the restroom at bedtime. So frequency, urgency, and nocturia. All of those will be there. Dribbling is another one we complain of, which basically means that the urine will just come out, will dribble out in drops. They won't have a full stream of urination. So all of those are the obstructive or the blockage signs and symptoms of prostate cancer. The metastatic signs and symptoms have to do usually with the lower extremities. So the lower extremities will be weak. Some of them will even feel a little paralyzed at the lower extremities. And they will not be able to get a full erection. So no full erection, may even experience the erection dysfunction, erectile dysfunction, that situation. They will be anemic, so anemia would set in, feel a little weak. And then, of course, they can see blood in the urine. And nothing sends or makes a man go to the hospital faster than seeing blood. So that's why they will actually come in the first time when they see blood in the urine. So those are your signs and symptoms of prostate cancer. And then in terms of the treatment, you have the 3 modalities. Of course, you have surgery, for instance, orchiectomy, the removal of the testes. And then, of course, you have radiation. And for radiation, they can use external beam, or that radiation process. In this situation, they usually use like iodine 125, let's say palladium also used. Palladium external. But this is strontium-89. It's a radioactive substance. Samarium-153. So those are some radioactive substances that they can use for radiation therapy. And then, of course, we have drugs, which is what we're getting to. The diagnosis, so we'll get to drugs. The diagnosis for prostate cancer. The first one is that direct rectal examination. And I would say that's the only time you should let anybody give you the finger. So that would, they'll feel the grown prostate, and it will be solid, And so they can use that in combination with the prostate-specific antigen number and get the beginning of diagnosis before they use other more specific methodologies. Okay. Then they can use the transurethral method. In which case you're just trying to visualize the prostate by putting a tube through the rectum, basically. There's something that is called the TURP, but that's more of a surgical thing. It's a resection of the prostate. That can be used for treatment. It can also be used for the diagnosis, of the prostate cancer. And of course, they can use the MRI for diagnosis, things like that. And the only one that is specific is biopsy. So you have to take a tissue out of that prostate and then go to the lab and see if it's cancerous. That's the only specific diagnostic tool. So in terms of the drugs, we can start off with that Sipuleucel. Sipuleucel T, you can see it as Provigen. Provenge. That's the brand name for it. And basically what you do in Provenge is like a vaccine. So we usually say that this is an autologous system. Autologous cellular chemotherapy. Because what you're doing is you're taking the patient's own T cells and you're training the T cells to recognize those prostatic antigens, the ones that are said will be exposed on the, expressed on the surface of the prostate. And you're combining that with APC, an antigen-presenting cell. Okay? So you then will introduce the entire thing into the patient. So you have the antigen, which is what is produced on the surface of the prostate cell. You have the T cell that is supposed to respond to that antigen. And then you have antigen-presenting cells, which are cells that will normally take any antigen that comes to the body and present them to, like your B cells and T cells. So the formulation that you now put back into the body will recognize those antigens on the prostate cancer cells only, and they will react vigorously because we've trained them to basically recognize only those prostate cancer cells. So actually, when you give sickle cell T, you will see an increase in the activation of your normal APCs. So your antigen-presenting cells will have a significant increase in terms of their ability to present antigens to your immune system. Okay? So you'll see that with sickle. You will see also an increase in the activities of the cytotoxic T cells. So the cytotoxic T cells will be very aggressive or will be more effective against any cell that has that antigen on its surface. Okay. So one would see an increase on upregulation in your T cells. And so that would basically help your prostatic cancer patients. The overall activity of the immune system will also be upgraded or upregulated when you give this syphilis T. There is a similar thing that is now being developed for breast cancer. Okay. Because the breast cancer can produce an antigen that is called immune. So that drug will be called Nuvenge as opposed to Provenge or prostate. Called Nuvenge. So that's one drug that you can use for managing or treating prostate cancer. And of course, we know you have the taxanes that one can use, and of course, cabazitaxel is the taxane that is used mainly in prostate cancer. Cabazitaxel. That's the one that is mostly used in prostate. The others, paclitaxel, docetaxel, they can also be used in prostate, but this particular one is used more for prostate than anything else. Extramustin is another drug, and you see if you break it, there is a high dose of estrogen that is combined with an alkylating agent, nitrogen mustard. So that combination is used well It's a combination drug by itself, but sometimes it's also combined with other drugs. For instance, there's a combo that's called DED. That consists of docetaxel, which is a taxane, extramycin, that's the E there, and the last D is dexamethasone. So that combination can be used when cabitaxel is used, or even when docetaxel is used. Each one of them can be combined with your prednisone. That's a combination regimen. So it's either docetaxel prednisone or your cabazitaxel prednisone that can be used in prostate cancer. Anthracendione mitoxantrone or novantron, that is also used to treat prostate cancer, and it can also be combined with prednisone as a combination agent. Then you have your 5-alpha reductase inhibitors. So basically you have testosterone being converted to dihydrotestosterone, and it is this DHT that will go into the nucleus, okay, and will give you an increase in the growth rate of your prostate cells. And the 5-alpha reductase, that enzyme is what is responsible for that conversion of testosterone to dihydrotestosterone. So testosterone will not act by itself in the nucleus. It will have to go to DHT first, and the DHT goes to the nucleus and would activate a gene which would then be translated to the protein. The protein is what will give you the growth of the prostate cells. So the 5-alpha reductase inhibitors, drugs like your Proscar, drugs like the Testeride, and there's a drug that is called Jalin, which is a combination agent. If you combine tamsulosin with the Testeride, you'll get Jalin. So Proscar or finasteride, that's your finasteride, the Testeride, those ones are 5-alpha reductase inhibitors. And the saw palmetto that we mentioned earlier also works by inhibiting 5-alpha reductase. Okay, so 5-alpha reductase inhibitors, you have 3 of them mainly: finasteride, Testeride, and saw palmetto. Jalin is a combination drug of the Testeride plus tamsulosin, already combined into one. Because when you're treating, say, PBA and benign prostatic hyperplasia, you usually combine a 5-alpha reductase inhibitor with tamsulosin. And of course, the purpose in BPH is the finasteride or the testeride would decrease the growth of the prostate cells, and the tamsulosin, being an alpha blocker, will relax the muscles of that prostate so it doesn't choke the neck of the urethra, so urine can flow through. That's the reason we combine those. Okay. Now, in terms of prostate cancer, these agents are not good for treatment. They can decrease your risk of getting prostate cancer, but they do almost nothing to an established prostate cancer. So, you prefer to use them at maybe at early stage or preventative stage, as opposed to the treatment. It's a drug called Oncorad, and if you break it down right there, oncology radiation. That's the name of the drug, Oncorad. And it basically just uses an antibody in combination with a radioisotope. Lutetium-90, lutetium-99. So that's a radioisotope, yttrium. So you combine the yttrium plus, an antibody. That combination is what you have in Oncorad. That seems to be the ongoing thing today when developing drugs. If you have an antibody that is considered a biological molecule, and that can actually be joined to either a radioactive isotope or a drug that would do something else, like a drug that would, let's say, inhibit the mitotic process, or a drug that will interfere with the cell cycle growth. So that seems to be the ongoing thing. Today, but we mentioned stages like that on Wednesday. So we can see these drugs. Okay. I'll just mention as number 7 there, a drug that we've already seen, which will be your PARP inhibitors. So we already mentioned that, like olaparib, for instance, which we discussed under breast cancer. The other agents that you see listed there, we mentioned them on Wednesday. Those will be things like your anti-androgens, those that are steroidal versus those that are non-steroidal, your gonadotropin-releasing hormones, analogs, and then gonadotropin-releasing hormone antagonists. We'll do that on Wednesday. Questions?
So you said the 5-alpha reductase drugs are not the best to use. However, are they being used Oh, you said prevention.
Just wanted to clarify for prednisone, you said it can be combined with Novitrone. It can also be combined with docetaxel and
Docetaxel?
and then
Cabazitaxel?
anything else or those?
Yeah, docetaxel. You have other combinations that you use in prostate cancer, like what we call the FL regimen, which is the flutamide and leuprolide. We have the FZ regimen, in which case we're talking about flutamide plus Zoladex. So I was going to bring those up when we're talking about the anti-androgens. Because we have Zoladex and we have Casodex. That's actually another combination, Casodex, Zoladex combo. We'll mention those.
So it's a piggyback, so that's a four-drug combination with no prednisone, docetaxel,
And that's the taxol.
yes.
Yeah, those, and each one of them, it's not like 4 drugs.
Oh, okay.
No, each one, like docetaxel for prednisone, that's one.
All right.
Docetaxel for prednisone, that's 2.
For cervical cancer prevention responsible cyst plus MOB, what was the MOB?
What was the MOB?
Yes.
Mom. You know? You don't know Mom? You've never lived in New York? Huh? Okay. You're just talking about your methotrexate being used, your amphotericin being used.